Okay, I think we'll go ahead and get started here. So this is the yearly Daniel Schuster lecture. For those of you who didn't know Dan, he was really a critical person here at the Department of Medicine and the medical school. Not only was he a world-renowned researcher in acute lung injury and ARDS, really being a pioneer in using PET imaging to really understand the pathophysiology of that disorder, but he was also a great teacher and an expert clinician. He did a lot to advance clinical mentorship and sciences here at the university. Really, he was the one who set up the master's program in clinical investigation. He also set up the Center for Clinical Sciences here in terms of allowing clinical studies to be performed in a very effective manner, helping other clinicians and clinical scientists carry out their studies. Dan also obviously was well funded throughout his career, and he was a great mentor to many of us who are still here and have gone to other places. So with that, I'm really privileged to introduce Margaret Herridge as the 2023 Schuster Lecturer. Just very briefly, you have Margaret's brief bio in front of you there, but she's really recognized as probably one of the premier outcomes researchers in the field of critical care globally. I mean, when you talk about chronic critical illness, critical care outcomes, her name is always at the top. She's been recognized, obviously, globally, but within her own institution, she's a professor of medicine. She's a senior scientist in critical care and respiratory medicine, a Tier 1 Canada Research Chair in critical illness outcomes and the recovery continuum. And she's the director of critical care research at the University of Toronto. And if you look at the New England Journal of Medicine, she's got a series of her papers that have been published focusing on outcomes in critically ill patients. So with that, please help me in welcoming Margaret to give the Schuster Lecture this year.
Thank you very much, Margaret, and it really is a privilege for me to be here today. And Marin suggested this title, so the alliteration is his fault. In Canada, indeed, I am a Canadian, COVID and chronic critical illness crisis and alliteration. So this is what I'm going to talk about today. I'm just making public my disclosures, and I will say to you that I have no conflicts of interest to declare, and I have no relationship, nor have I historically, with either pharma or industry. And I did want to say what an honor it is for me to be invited to lecture today and to be contributing to the Schuster Lectureship. I did not know Dan Schuster very well personally, but I certainly met him a few times early in my career at the ATS. And I read through some of his papers before I came here today, on this visit, looked at some of the website tributes, some of the tributes at his obituary site. And Marin highlighted a lot of his seminal contributions academically, but clearly he was someone who people held in enormously high esteem and was a very valued colleague and wonderful person. So I really am very honored to give this lecture, and I thank you for the honor of that. So I'm going to just refresh this. I'm going to talk for about the next 40 minutes so that we have a lot of time to discuss. And here are some objectives for the talk. I really wanted to give you folks a bit of a state of the art in critical illness outcomes for both patients and families. I have like 2 microphones. Is that a problem? This may be easier for me. Is that okay? Yeah, thanks a lot. Okay. No problem. So I'm going to talk about, give you sort of a state of the art in critical illness outcomes for patients and also for families. And I will just say that I think a lot of physicians who are to the for the ICU, but also ICU physicians really do not read nor prioritize the outcomes literature. And that's not an indictment. It's just because we're very focused on ICU outcomes. But I hope that what I'm going to say today will be enlightening and really understand how we risk stratify patients, because it's not hard to understand who's going to do better or worse in the ICU, what the published trajectories of outcomes are, the various, and there are many of these post-ICU syndromic constructs, and how we should maybe begin to think more about aligning these with goals of care discussions and educating our patients and families about what it looks like to survive a very severe episode of critical illness. And then I'm going to talk, and I guess this is where the Canada part comes in, a little bit about COVID, in which we've all been through a very difficult time around the world. Certainly we experienced a lot of hardship as well in Toronto, and to talk a little bit about that and to just share some results from our Canadian national COVID follow-up study that I'm leading with my co-PI, Angela Chung. So I'm going to talk a little bit about that. And here's just a bit of an overview to give you a sense of the order in which I'm going to talk about these things. Now, I just wanted to start off by saying that there are very clear syndromic constructs in the post-ICU literature. And this may be something that you're more or less familiar with, depending on your interest in reading this literature or your exposure to it. And I'm going to use some of these constructs to outline and give you folks a bit of the history of critical illness outcomes, because the published work in this area has really been going on for decades. And still, it's really not part of our ICU lexicon. And I personally perceive that as a little bit of a tricky issue, because we really do need to understand outcomes to be able to take good care of our patients and their families in the ICU. So I'm going to talk about, excuse me, the post-ARDS syndrome, the post-sepsis syndrome. These were emerging syndromes. I'm going to spend a bit more time talking about the concept of chronic critical illness, and then how these have sort of intersected to the current construct of the post-intensive care syndrome, coined by Dale Needham, who is actually our fellow in Toronto, a former mentee of mine, and the recent extension of that from the European group from Jean-Charles Prisset. So the outcomes literature really began with a vengeance in the late 90s. And the person who really put PTSD on the map after ICU is a German colleague of ours, Gustav Schelling. And he really shook things up quite a bit with his paper in critical care medicine in 1998. And I think people were pretty stunned by these results, that patients after critical illness, and in particular in this sort of post-ARDS construct that I'm building here with you in this discussion, had very significant post-traumatic stress disorder. And I think people were really shocked by this. But what this initial and seminal observation did was it elevated awareness about this. And many people around the world have confirmed and substantiated this as a major morbidity after critical care. And these early data in ARDS have been generalized to sepsis, to chronic critical illness, and now to COVID. And our COVID survivors have pretty significant PTSD. The next paper after this was a very important paper by Mona Hopkins. And Mona Hopkins is a colleague. She's in Salt Lake City. And this is an important paper from 1999. So it's a long time ago. And she really put the concept of neuropsychological dysfunction and long-term neuropsychological sequelae on the map, again, in the post-ARDS patients. These patients after acute respiratory distress syndrome, who typically will be very sick, are high acuity people who've spent weeks with us in the ICU. And what she was able to show was that these patients typically had decrements in memory, concentration, processing speed, and had a lot of difficulties with executive function. So really the ability to organize and the ability to multitask. And you see this when you do follow-up, and we have a big follow-up program in Toronto. And this has really been extended by subsequent work of hers, which shows that one of the reasons why patients have, I'll just maybe step away. It sounds like I'm in a wind tunnel or something periodically. One of the reasons why this happens is that there is activation of the microglia and the CNS, and actually there's neuronal apoptosis in the brain, and an age and neuronal loss and age inappropriate cortical loss after severe critical illness, not just in ARDS patients, but in sepsis and other patients as well. It's really not diagnosis dependent. And in this very important New England Journal paper led by Pradip Pandurapandi and Wes Ely, and of course, Wes has contributed so much to delirium and neuro outcomes after ICU, we see that delirium and duration of delirium is one of the most potent risk factors for neurocognitive dysfunction. And that the neurocognitive dysfunction is actually age independent, as you see here in these tertiles of age, and on the order of mild Alzheimer type dementia or moderate traumatic brain injury, which I think is a rather stunning observation, but again, very robust observation. And other authors, Mark Michelson has also shown cognitive dysfunction in his study of ARDS patients. And then more recently, an important paper by Jim Jackson, part of the Vanderbilt group, again corroborating the disability, and here, doing functional disability, but also mood disorders in addition, so depressive symptoms and PTSD. Now, I'm just showing you a paper from our group in Toronto because I'm going to show you that this is 20 years old. I like to kind of make a joke that, I was sort of in high school or something when I did this, but I wish. Anyway, I was talking to a colleague today over breakfast and saying that in my career, it was important for me to stay focused because I'm married to a transplant surgeon and have 3 children. And this was my project. This was my first project when I came on staff at the University of Toronto. And it took all my time. But I just want to explain that it changed my career to see people in person and to listen to their stories and to listen to what their family went through. And this this paper really has launched a lot of the questions that we've had, and those questions weren't my questions. The questions I've tried to answer came from the patients and the families, and spending a lot of time listening to them. And what we found in this very young cohort, who honestly were extremely ill, as sick as the COVID folks that many of us have been looking after in the unit on the last, couple of years, and 40% of these people died, that they have a lot of trouble. And in this young group, the overwhelming observation was that they had very profound weakness and muscle wasting. And this ICU acquired weakness was a major, major morbidity for them, in addition to a lot of the neurocognitive and mood disorder sequelae that I've already explained to you. And this resulted in a lot of functional disability and a very protracted rehabilitation period, and a trajectory that really, I think, is a year or longer. But in addition to that, a lot of multimorbidities here, I've listed some of them here: alopecia, chronic pain, various neuropathies, heterotopic ossification, and extraarticular bony deposition related to immobility, various contractures. I mean, there's a lot of iatrogenesis that these patients sustain because they've been with us for a long time. And I'll talk about that a little bit in a minute when we get to the chronic critical illness discussion. But just to set the stage for that, and a lot of research on ICU-acquired weakness. Here's a very beautiful schematic in the New England Journal, a research paper led by Jesse Hall and J.P. Kress in Chicago, showing the fundamental lesions of ICU-acquired weakness, and they are quite specific. It's a myosin depletion myopathy that these patients have, and an axonopathy. The The myosin depletion myopathy tends to have a better recovery trajectory. The axonopathy, and like patients after Guillain-Barré syndrome, when the axons are affected, they tend to have longer term and often irreversible motor sequelae from that. But you can see this is prevalent, you know, you go through I'm sure if I went through your ICU, like in ours in Toronto, we have many of these people who are chronically critically ill and they're profoundly wasted. This muscle will not necessarily recover. And this is a misunderstanding about what rehabilitation medicine does. This muscle injury, and you can see here in the micrograph here, the myopathy is characterized by, you know, a loss of muscle fibers. They're angulated, they're multinucleated, and people may not necessarily recover or may recover differentially muscle mass or contractile force. And just in the interest of time, I'm not going to go through all these papers, but I want to make the point that the diaphragm is the most vulnerable muscle group that we have, because teleologically, it's the muscle group that was never evolved to rest. And when you put the diaphragm to rest, it undergoes enormous and rapid and early proteolysis. And this is through the upregulation of the ubiquitin proteasome pathway. And that's part of the stress response. This is diagnosis independent. So the diaphragm degrades rapidly, and this is why we can't get people off the vent, one of the reasons. So that's a bit of a discussion about post-ARDS. Now, what about sepsis? Well, this is a seminal paper from Jack Washina, really teaching us that after an episode of sepsis, there's very important both functional decrements that never return to baseline. And you can see that here both in does this act as a pointer? Yeah. Both before sepsis, had a mean number of activities of daily living and instrumental activities of daily living and limitations, and after sepsis, a real decrement in function. And looking at the cognition similarly, and this is similar to what I showed you already from Mona Hopkins' seminal work, that people with more modest cognitive impairments had a very pronounced exacerbation of those impairments after sepsis. So again, kind of recapitulating these important domains. Now, let's just talk a little bit about the syndrome of chronic critical illness, because this is going to be the major issue of the next several decades, quite frankly, and is already a very major emerging issue around the world. So the syndrome of chronic critical illness was actually first described by Gerard and Rafin. This was in a paper in Respiratory Care. It's well worth reading, 1985. So you see that my messaging here is this is nothing new. It's just now we have more of a problem with these issues because our population around the world is getting older and more comorbid. And these are the folks we can't liberate quickly from our ICUs and from the vent. It was really put on the map more recently by in this paper in the Blue Journal, led by Judy Nelson, Chris Cox, and Shannon Carson. I'm sorry, I don't know who Hope is, but and also by Terry Huff and Terry with Shannon and the ProVent investigators. And what they really did is you'll recognize a lot of these syndromic characteristics here, but really in the context of more chronicity. So we're thinking more about patients who have all the things that I've already talked about, but typically are older population. They have a lot of chronic comorbidities. And we're looking at things like pressure injuries, which are a major source of morbidity, in addition to a lot of the other issues that I've spoken about. And the different definitions, I just wanted to say too, that there are different definitions of this. I think historically people started at sort of like 4 weeks, you're chronically critically ill. Then it was sort of 3 weeks, probably 2 weeks. This is the ProVent 14 paper that I've shown you here from Terry's group. And we did our own study in Canada called the Recover Study. And actually we looked at survivors of 1 week of mechanical ventilation, which I think in an older patient population that's comorbid can also serve as a time threshold where people are really declaring themselves as getting into a lot of trouble. Oh, and I did want to say the mortality is very high. So the mortality is predictably 50%, but 70% or even more, not uncommon. And the folks who survive have a major change in disposition usually, and a lot of comorbid illness. So here's just, I've already really referred to Terry's paper here, but their one-year mortality modeling highlighted again the importance of age, which is not being ageist, and people who required pressor support, renal replacement therapy, and medical admissions, non-trauma admissions. And these were the determinants of a higher one-year mortality. And in this paper by Jeremy Kahn, this is from some of the members of the Pittsburgh group, and Shannon's part of this too, Derek. So you'll see that this paper's, approaching 10 years old now. And the costs of the chronically critically ill are immense. They're immense in terms of what the patient-centered costs are, with only 20% of these patients even being able to return to home. Most people were discharged to skilled nursing facilities, a lot of death, and in this older paper, incurred costs of $25 billion. So you can imagine what they are now, and you can imagine the costs that we've incurred in the past 2 years with our critically ill post-COVID people, and those costs will be ongoing. And I think this is an important message I want to leave you with. Now, I really wanted to also give credit to Dale on this construct, the post-intensive care syndrome, which has overlapping features with the other syndromic constructs that I've mentioned to you, dating back to 1998 with Gustav Schelling's paper. And then more recently, this extended PICS by doctors, I mentioned Rousseau, but the senior author, Jean-Charles Prisset, who's in Brussels. I would mention that one of the reasons to keep extending this is the PICS definition did not include frailty, and frailty matters a lot. It's a major determinant of mortality and morbidity, and that these patients have a lot of comorbidities. And these are pictures from our own work in Toronto in our Recover study. These people, this is a year later after they left the unit, frozen shoulders, vac in situ, with an ostomy from complex intra-abdominal sepsis, primary closure by primary intent, secondary intent, and lots of very severe striae from volume overload. So lots of things that really can destroy someone's life that we don't really think about too much in the ICU, but I would like to argue that we should be. And I'm not going to go through all this list, but I'll just highlight a few things that I think people are not really aware of. People have their teeth and gums ruined in the ICU. Dental caries and tooth loss are rampant because we do not brush people's teeth. And their oropharynx is completely colonized with all the pernicious bugs that are the causes of their ventilator-associated pneumonias and their complex pressure injuries as well. People have a lot of hearing loss as well. And this is not from aminoglycosides, it's from Lasix, because we push Lasix, and we should not be pushing high doses of Lasix because it's an ototoxic agent when administered in this way. So just to highlight many things, another thing that people forget often about is dysphagia is very debilitating. And this is because the muscles, the pharyngeal muscles, and swallowing is a very complex motor procedure actually, are also affected by ICU-acquired weakness. So this is another risk for aspiration and repeat ICU admission because of these long-term consequences of ICU-acquired weakness. I'm just going to highlight a few things. This is a fasciotomy scar from an ECMO patient. These are what the cannula looks like after you take them out in someone who's actually a poor wound healer, and that is sort of variable. These are 1 year later, trach site 1 year later, and even having the ties tied too tightly, things that another reason, we were talking last night at dinner to go in and examine your patients, please. If you worked with me in Toronto, I would drive you crazy by telling you that. Critical care is not a zoo. Critical care is we go in and examine the patients because we're doctors too. And these are the things that you will miss. You will miss seeing that the ties are too tight and this patient needed a plastic surgery. And I'm not being self-righteous, right? I make these mistakes myself every single day. I have to remind myself, have I gone in? Have I talked? Have I seen somebody, have examined them? Do I actually know the details of what's going on with them? But this man had to have plastic surgery procedure of his lip because of ties that were on too tight, and he was anasarchic. 1 year later, this is a pressure injury because the microbiology of this is really complicated, and it takes ages for these things to go away. This is 2 years later. This is in the ICU, but this patient has been there for months. The pressure injuries are really morbid, and they're colonized now with multiply drug-resistant bugs, and it's very, very hard to get rid of them. And you can't go to work like this. I mean, that became, I guess, irrelevant during COVID because we were all sort of doing a lot of remote work, but you can't show up with an oozing ulcer on your head. Like, you can't work like that. And you can't wear shoes when your feet look like this. So you don't think about this so much in the unit, but it has a profound effect on what happens to someone later. And I love this diagram. This is from Chris Cox's group. And I love this diagram from Mark Monroe is the first author here, because it's not actually intended for you to read all the fine print. It's just intended to show you the Byzantine pathways that our patients travel after they leave us. They're trapped in a million care transitions, in particular the chronically critically ill patients, because they cannot get better, because they've exhausted their reserve, excuse me, and their resilience, and they're really struggling. And this is a very nice paper from Hannah Wunsch, and Hannah's in Toronto with us currently. She came up from Columbia to join us in Toronto, and really showing again over a 3-year outcome period that so many of our patients will end up in a skilled nursing facility. So they have a real change in function and a real change in disposition as a result of that. And that this lasts for a long time. So when we followed our ARDS cohort out to 5 years, and remember I told you that these were people who were in their early to mid 40s, and they weren't comorbid. This was a long time ago when our ICU had fewer patients like this. And 5 years later, these people really never got back to baseline. And I'm not showing you the economic data, but we did an economic analysis of these patients, and they had a higher than predicted for their age and sex and sort of comorbid controls for healthcare use and costing. So in Canada, that's less money, but it's still a lot of money, and it continues. So people are now on a new healthcare trajectory and on a new costing trajectory. And this is a really a big deal. Elizabeth Foe, who works with Dale's group at Hopkins, and Dale built his ICAP cohort based on our ARDS study. This is their 5-year data from their ICAP cohort. And Elizabeth and Dale show here very similar, that the patients don't get back to normal. And actually, a lot of them have health declines over time. It's not just that they're stable, but they've been declining in health. And one of my other colleagues, Brian Cuthbertson, who came to Toronto from Scotland, showed that similarly in a 5-year outcomes paper. So I really wanted to, let's see what time it is. I really wanted to, I wish I could give you a whole talk on this, but I really wanted to impress upon you how having a loved one in ICU changes the life of the family. And so I'm not trying to be lecturing, or I guess I'm doing a lecture, but I'm not trying to like berate people that, you're not, examining people. We struggle with this in Toronto for sure. That's why I'm making a point of it. it's really important to make contact with a person, and the patients will tell you that they remember the people who examined them, touched them, because they feel so physically isolated in the unit. And it's very orienting to have a conversation, to be examined. You'll miss things if you don't go in every day and examine people. Trust me, it's not on the flow sheet. It's not in the EMR. But the other thing that's important to do every day is to talk to the families if you can. You don't need to talk to people for half an hour. You really need to talk with them so you develop a relationship with them, that you tell them that you're basically communicating to them that you're paying attention to their loved one, that you're there to be transparent and to communicate honestly about what's going on and not create false hope or ambiguity, because we know who's doing well and we know who's not. It's not a mystery. And we really need to be having very honest, direct conversations with that, and continuously, because the only real mitigating thing for patients' families is excellent communication, the only mitigating factor for their mood disorders. And believe me, they get very sick with mood disorders. Just like the patient data that I showed you, there's a huge literature on family caregiver mood disorders, anxiety, depressive symptoms, PTSD, suicidality, and substance misuse. And it's because people are out of control. They have unremitting stress and too much uncertainty. And honestly, when you live with that for not just days, but weeks, it destroys you. And it really is important to understand that, to not judge, and to try to really spend time talking to these people, because it's therapeutic. It's not being nice. It's really part of our job. And I'm just showing you here, this patient was in our Recover study. This young woman on ECMO, on dialysis, extremely sick, but 30 years old and previously healthy. This is the person we go to the wall for, because she's got so much resilience and reserve. But even when, this is her husband, who's a lawyer in Toronto, and her twin daughters, it was pretty rugged rehab. She had pretty serious mood disorders, and so did her husband. So it's a big journey, even when you start out young and previously healthy. So I'm going to speed up a little bit here. I just wanted to talk again about risk stratification. So this is all getting to COVID in Canada eventually. Age matters a lot. And as I said before, it's not being ageist. It's because even if you're a healthy 70 or 80 or 90-year-old, you have a loss of organ reserve over time. That's what normal aging is. That's why age matters. And we know that we have cortical loss on average over decades. We have a drop in our FEV1, we have a drop in our ejection fraction, and we have a drop in our GFR. That's normal senescence, that's normal aging. So that's why age matters a lot in outcome, and it's a robust determinant of outcome in all of the models that you see in the literature. Here's some very nice data from Lauren Ferrante, really underscoring what I showed you from Jack Washina's data and others, that the pre-ICU functional trajectory is the, maybe not the, but one very important determinant of post-ICU outcome. So when you're taking the history, maybe not from your patient, but your family members, because they're the witnesses to the history, who they were before they really became sick matters a lot. Were they already hospitalized and declining? Or were they high functioning in the community and entirely independent? You see, this is an important clue about how they're going to do when they become your patient in the ICU. And it, you see the people who are having problems before, like Jack's paper, you know, they're having even more problems afterwards, because everyone has a decrement in function from where their pre-ICU baseline was, and add to that all the multimorbidities that I've talked to you about, the cognitive issues and the mood disorders. And frailty matters a lot, as I mentioned. It's a determinant of everything. ICU mortality, ICU length of stay, hospital mortality, 1-year mortality. It's a very important risk stratifier and a risk determinant. Now, how weak people get in the unit, and weakness is a function of age and ICU length of stay, you can understand trajectories of weakness. And here, and this is work from Greet Hermans in Germany, She works with Greet Vandenberg, who's a very important researcher in neuro outcomes after ICU. You can see that the trajectories of weakness stratified here by the Medical Research Council score has a lot to do with your survival. So these very debilitated and weak folks that we see in the ICU really have a lot of problems in the longer term and important to pay attention to. Our own group in Toronto, this was another cohort study that we did, and we looked at everyone after who'd been mechanically ventilated for 1 week or longer. And it turns out that 1 week, this is a very diverse case mix. Turns out that 1 week is a bit of a threshold for being in the unit, at least across Canada. This is a multi-center prospective cohort study for 2.5 weeks. And that at 2 weeks, patients get on trajectories. And you can see the trajectories here. These are people who are around 40, who've spent fewer than 2 weeks. These are people sort of 40 to 55 years of age. These are people who are 55 to 65, and these are people who are over 65 years of age who spent 2 weeks in the ICU. They have mortality of 40% and a lot of morbidity out to 1 year and beyond. And these trajectories, and we didn't construct them, they just were distributions in the data set that we evaluated through recursive partitioning modeling. And these trajectories determine a hospital and ICU readmission. So it's not an accident. You know, we know the people who come back to us in the ICU, often multiple times before they ultimately die with us because they can't get better. And not getting better is really important to pay attention to. And the disability, a week after ICU discharge, your age by decade, your ICU length of stay by week. Every week you spend in the unit, your risk of 1 year mortality increases. It's not a neutral proposition. Every week beyond 2 weeks, that's our modeling, but other groups have really shown that too. The French Frog ICU group, Bernard Guidet, who is a French investigator, typically studying older patients, all of these things matter. And Charlson, the comorbid burden matters a lot. Okay, so I hope I've been able to convince you that the patients in ICU have a lot of morbidity. We've had a very robust and long-standing history of outcomes, but not so much uptake of this information in our ICU community. It really isn't part of our vocabulary, not really part of our lexicon, and I hope that I'm persuading you to read this literature and to think a lot more about this at the bedside. Now I'm going to switch gears here in the last few minutes and just talk about COVID in Canada. And, you know, like you folks, we had a lot of COVID in Canada. Omicron was the worst for us, like it was for you, and a lot of deaths. And we have a lot of people like you folks do now with the post-COVID condition. If you want to use the WHO terminology, or long COVID, which is really the terminology that's come from patient-led groups. But the point I want to make here in this talk, because I'm talking about ICU outcomes and chronic critical illness, is that what COVID-19 did is it created the largest cohort of ICU survivors in history. And that's a very, very big deal for all of us around the world, because we have a ton of people with a lot of morbidity. And that's why I spent so much talking about that at the beginning of the talk. So we all saw this paper when maybe we all thought this was going to be a problem in China and was never going to come to North America. And then all of our models began to show us it's coming. And we began to prepare and feel frightened about what we were about to face. And and it was terrible, all of it, for our poor patients, their families, and everyone else. And for us, it's changed critical care forever. So I just want to recapitulate what I've already said, which is that COVID-19 is a multi-organ dysfunction problem. Now, the pathophysiology isn't exactly ARDS. It's not exactly sepsis. It's not exactly chronic critical illness, although these critically ill people spent a lot of time with us. But the overlap is fundamental. And we need to understand that and learn from it and not think this is an entirely new entity, because a lot of the problems are very recognizable, and renal failure here. And the other thing that we need to learn from is how we completely de-adopted the A to F bundle in COVID in a horrifying way and around the world. And it's not an indictment. We did this in Toronto. It was just because it was so hard to do these things. The patients were so sick. The delirium was so bad. For sure in Toronto, we were using a lot of ECMO and we couldn't control, the delirium on circuits. We were having problems with the circuits. So people were in a deep coma. They never moved. Family were distant. We didn't talk to them because we were strung out ourselves. I mean, everything that we know we should be doing, we didn't do. And that's absolutely exacerbated the morbidity that I just showed you and the ways that we can historically mitigate it. So I'm just going to run through just a couple of COVID studies and then finish with sharing a little bit of data from our CanCove study, which is we're going to be finishing our one-year outcome in April, and I'm going to present those data at the ATS this year, if you folks are there. This is from Hallie Prescott's group, and Hallie's done a lot of important work on sepsis outcomes and is a very important leader in this area now. But you can see here that, and things I want to highlight to you, that a lot of people really had problems returning to their activities of daily living. There was clear emotional and financial impact. And even in Canada, where we have a single payer system, if you're a self-employed person, this was a disaster for you. And your business, everything else fell apart. So there are financial implications all over the world, even if you're not paying directly for healthcare, even though we pay for our system through taxes. This is an important French paper from the Comeback. I'm just going to show you a few international studies. This is the Comeback group, again, showing a lot of important challenges in these patients. Let's look at the intubated group. They were weak. A lot of people with persistent cough, decreased function measured as the distance walked in 6 minutes, some pulmonary sequelae, some fibrotic lesions, pulmonary dysfunction, cognitive issues, mood disorders, anxiety, depressive symptoms, PTSD. So exactly what I already showed you. And by the way, we should expect that. This has been Kao's cohort. Bin is the intensivist who's led his group's work in Wuhan. This is the original Wuhan cohort, and he is the lead intensivist there. And I draw your attention to the scale 5 to 6. These are the people who are on high flow, non-invasive or invasive mechanical ventilation. Many symptoms, but the symptoms non-specific a bit in the ICU people, because we know that the post-ICU people have these problems too. But again, trying to emphasize how these patients had multidimensional disabilities. You see the EQ5D, 5L, multiple problems in domains, quality of life, and challenges with disability here captured as the distance walked in 6 minutes, some pulmonary dysfunction, and chest CTs, most of them GGO, so ground glass opacifications, which actually, and we learned from we did a 1-year SARS cohort, these will tend to resolve over time with or without fibrosis. And at 1 year, a persistent challenge with return to work, persistent challenge in some physical function. So really long-lasting sequelae. So in the last couple of minutes, I just want to introduce, but not give you a talk on this study that we did in Canada. This is a multi-center ambidirectional cohort, actually. Part of it's retrospective because it took us a while to get REB and contracts organized. And then we began to recruit prospectively, so it's mixed. We're trying to message our diversity in Toronto and in Canada in our logo here. And I'll just show you a little bit of what we did. We have a large cohort. We have almost 2,200 patients in this study. But what I'm going to show you a little bit here is just the hospitalized ICU cohort, where we're almost 400 people, and a smaller group of caregivers compared to our Recover study, because most of the caregivers were traumatized and they said they didn't want to be in the study. I just want to show you the contrast between a very sick cohort from 2003 and a very sick cohort from 2023. It's 20 years of my career, basically. And I want to show you a few things. that if you're vented, the mortality was about the same. And the other thing I want to show you is when you're trying to salvage maybe the unsalvageable with ECMO, your mortality is going to be even higher because these people were even sicker. And you'll rescue some of these people, but some you will not be able to. And I think that's an important message. And people are chronically, critically ill. They stay for a long time. Our group, this is just really brief because I didn't want to spend too much time talking about this, but disabled, exactly what I've already told you. Functional independence measure, they have multidimensional disability. The physical and mental component scores are low, very high mood disorders and PTSD, very high PTSD in ECLS. We can talk about that. High stigma, low resilience, high healthcare use. Now, the only other thing I want to end with this is that when we compare this and look at how the multiple organ dysfunction score changes over time, you can see that the people who died, their MOD score continued to rise or plateaued over time, and actually in a relatively early period within a week, and definitely at 2 weeks, it's pretty clear who's not going to do well. And I would say looking at the MODs in CanCove right now, it's almost like I made the data up to look exactly the same. These are biological truths, and people separate early on using either the multiple organ dysfunction score, the lung injury severity score, and declare themselves early on. What do you do? How do you help? This is a whole other talk, but the point is that people really do need multidimensional follow-up. We have a robust follow-up program that dates to our ARD study. There are many follow-up programs around the world, in the United States, everywhere. But really, rehabilitation and isolation isn't the issue, really. It's that in the context of multidimensional longitudinal follow-up. And just some final thoughts. I've tried to talk today a little bit about the syndromic constructs, the risk stratification, the clear trajectories that patients are on, and it's not a mystery. And that chronic critical illness is the problem for the next few decades. And there's a lot of cost, a lot of morbidity, a lot of very bad outcomes, and a lot of futility. And COVID is very emblematic of a lot of the challenges we have, and really exacerbated by the de-adoption of a lot of our practice standards. The advocation of an ICU care continuum, which I think is extremely important because people have longitudinal needs for durable morbidity, and to really obviate the challenges of multiple care transitions as you recover from a very complex multidimensional illness. And risk stratification matters. It is not hard to know who's doing better and doing worse in the ICU. And we really need to talk very openly about this. And we probably can determine this through early modeling from organ dysfunction scores or lung injury severity scores. And really within about a couple of weeks, you have a good sense of who's in a lot of trouble and who's not. And we really need to counsel and guide patients, families, initiate goals of care discussions early and probably weekly based on the weekly increment in 1-year mortality. And I think we need to do a lot better job of educating the public and our ICU colleagues and stakeholders about what we're really doing when we bring patients to the ICU. And finally, I really want to say to Marin and to all of those folks, Vicki, thank you for the honor of giving the Schuster Lecture this year. I say hello from Toronto. It's a very beautiful picture of Toronto. It's a very multicultural, international city. I hope you'll come visit us. I love living there. And I thank you again for this honor and privilege, and happy to have some discussions. And I think these are the QR codes that you folks need. Thanks so much.
Thank you so much for that terrific talk. I do think we have time for a few questions. So, Steve?
Yeah, hi, Margaret. One was mandatory for all of our fellows to keep them down and to that, what they are.
Thank you, Steve.
Bob Senior is one of our leaders in pulmonary critical care and our group here forever.
Yeah.
Always said the most important piece of equipment in an ICU room is the chair. And I was disappointed to see some of the to intensive physical therapy and benefit.
Yeah. Yeah, Carol Hodgson's New England Journal paper. Yeah, yeah.
And
Yeah.
I wanted to comment on that. What about physical therapy? What about other interventions can we do to prevent or maybe we can't treat it?
Yeah, so thank you, Steve. I mean, the chair is key for sure. Chair is key for the patient, but also for the family to be allowed to be sitting there. I think that we've come a long way with ICU mobility and early mobility for sure. I think that maybe I can say a couple of things. One is that not everyone is going to get better with rehab. And I think that's an important thing. That's not a pessimistic thing. You need to explore it, but then understand it. Some people have so much muscle injury and nerve injury. They will have flaccid quadriparesis now forever, which is a tragedy. But it's important to try and to see and explore how much muscle bulk and contractile force people can recover. But it will be slow and it'll take months to a year if you're really sick like the folks. So I think that's one thing I would say. The other, and there's basic data on that to show that the bulk and the force can recover differentially. Actually, from some of my colleagues in Toronto, Jane Batt and Claudia DeSantos, who are basic researchers, have done some very nice work in that area. The other thing I would say in response to Carol's paper is that Carol's outcome was many months later. And I think one of the challenges, if you're going to do early mobility and study it, it might be really helpful to have a more proximate mobility measure or functional measure, because we all know, right? We have all this rehab in our unit and people get to a certain point, you send them to the floor, it may not be as resourced as well for rehab, and then the patients degrade and then they come back, right? And you go, what? You were mobilizing 2 weeks ago. What's happened? And they say, oh, no one could do rehab with me, or there was less rehab opportunities. So I think that might be one reason, Steve, why Carol's paper was negative. And I think too, there was a little bit of a signal for harm in her paper, but I think when you have very expert, seasoned physiotherapists, I would not worry about the harm, but it is crucial. And the only final point I would make is, when you mobilize someone, if you want to do it, they have to be off all their drugs. And that we absolutely create brain injury with drug use. And they need to be off the drugs to mobilize. So it's a reason to get people off the drugs. And the other thing is exercise helps cognition. And we know that from the dementia literature. And to mobilize, to be active helps reorient. It helps mitigate some of the cognitive dysfunction as well. So I would just maybe make those comments. Thanks for a great question. Yeah, sure. Janet was just asking, in longitudinal follow-up, what do we feel has had the most impact on patients and families? I always try to think of it as a dyad. Well, it might surprise you. Advocacy. Advocacy and continuity of care. I would say those two words. You might want to hear from me that, it helped people have a better functional outcome. It helped people be less mentally ill. And the only reasons why I think maybe those might have happened for some people is because we advocated for them. For more rehab, because you get a certain amount of rehab, and maybe it's the same in the US, I think it is. You get kind of a dose of rehab and then that's it. You're sort of better, that's it. Same in Canada, same in Ontario and Toronto. So advocating for more rehab, advocating for more mental health. And we always had, we have in our clinic, I mean, not just like me and our fellows and this sort of thing, but like a navigator because we've always thought the clinic had a very important role in knowledge transfer. So I've always had, our senior ICU nurses come a year at a time and work with us and sort of a navigator role, a longitudinal contact role. And the continuity and the advocacy are actually the issues, because these patients have no advocates, because they have no longitudinal care, and their primary care physicians do not understand all of these strange problems, not because they're not bright, but because they don't have our lens of having lived through this horrible illness with them in the unit, and we get it. That's the difference, I think. Sorry. Yeah.
Seems like that can all
Yeah.
back in that day, there were a lot more training, especially for families in terms of talking about
Mm. Yeah, yeah, yeah.
It seems like now just looking at getting to the
Right, you mentioned this last night. Yeah. Well, I mean, I haven't worked in an LTAC, but I've read about all of this, and I have, many friends in the US and Europe who do outcomes work, and we all talk to each other. Well, I guess the first thing I would say is that if you don't travel the journey with the patient, you don't get the journey. And when it's invisible to you, it seems like everything's probably okay, and it absolutely is not. That's maybe my first comment, which seems like maybe kind of a stupid comment, but we don't have LTACs in Canada, but this is a bit of an intermediate phase of prolonged mechanical ventilation or chronic critical illness that does need a home a bit. And I would say that as I've done more of this work, and through COVID, we had a lot of these people. So in Toronto, we sort of needed to build a few of these things. So I would say I'm currently engaged in leading the development and sort of the director of this. I would say the Ontario version of the LTAC, but it's not the LTAC. And what we have done is we created partnerships between the acute ICU and our sort of prolonged mechanical ventilation units, so that the intensivists who work in the acute units work in the prolonged mechanical ventilation unit. And then these patients get rolled into a follow-up clinic. And it was deliberate for a few reasons. It was to create knowledge transfer, actually, and to get patients out of a high acuity setting when they're not the stars of the show and they don't get the attention they need. And you can't get rid of delirium in an acute care ICU either. But I think even more so through knowledge transfer and having nurses go back and forth, physicians, the interprofessional team members go back and forth, which is what we've been doing. What we've also done is we've created an educational program for our University of Toronto critical care trainees to come and work at the prolonged mechanical ventilation unit and do follow-up in the clinic with me. And I would say that the feedback has been extraordinary. I mean, they're shocked. And I guess they say to me, oh, I get now why you say this on rounds to us or whatever, because it seems like I'm saying strange things, I'm sure, half the time, because my lens is different, but now they're acquiring the lens. And I think this is a key issue, that our trainees understand the care continuum, because you'll look after your patients differently, and you'll talk to their substitute decision makers differently, and you'll talk to our stakeholders differently. You'll say, do you know where this person is headed? Do you know where they're going to be in 2 or 3 weeks from now? It's known. Is this the life they wanted? Truly. And maybe some people, yes, but it's important to have that honest discussion for sure. So I think, Maren, creating knowledge transfer and experiential like powerful experiences that change your lens and change this is important. And I think if people are being moved systematically to an LTAC and are invisible, I could really understand why people might think the outcomes are better than they are, but they're not. And it really, it's a lost opportunity to be able to, have a very genuine kind of authentic discussion with families when you've looked after these people yourself and people recognize when you're genuine. And that you're trying to express to them what trajectory this person is on. I guess the only other thing, if it's okay to just add another piece to this, I didn't mention because I'm still quite horrified by this, but in our Canco study, we had a lot of people in ECMO in the Toronto General. And not just a sort of a 61% one-year mortality, which I personally find horrifying, but a lot of morbidity. But the other issue is the families are so sick. And we actually had the wife of one of our long-term ECMO patients hang herself because she couldn't, and she had no mental health problem, because she couldn't cope with this kind of, I call it purgatory, this state of suspended animation where you don't get better, you don't get worse, you don't die. And death is a completion event, and people need to be allowed to die, if it's not like too abrupt for me to say that, so that their family can have a completion event and mourn. Because it really, the families developed very severe mental health problems. And now the young adult children of this couple, the husband and the mother, are dead. The father and the mother have died. Developed very severe mental health issues themselves. And we were advocating, to get to Janet's question, for the kids because they had no one to advocate for them inside the system, right? Because all of our systems have been so disrupted by COVID. And all I could think about was the concept of intergenerational trauma, which is a big topic in Canada these days for all of those horrible reasons you've been reading about in the press, I'm sure. But this is an issue. And I don't think, I don't think it's wrong to tell families that their loved one is going to die. But we've really moved away from that. I agree with you.
Margaret, thank you very much.